Hello, my name is Mohammed Dilwadi, and I'm pleased to present to you a case of new onset refractory status epilepticus and Hashimoto's encephalopathy in a young patient after COVID-19 Moderna mRNA vaccination by Drs. Dilwadi, Al-Ghazawi, and Patel at the Memorial Healthcare System in Florida. New onset refractory status epilepticus, or NORSE, is a devastating entity characterized by superrefractory status epilepticus resistant to 2 anti-epileptic drugs and general anesthesia treatment for 24 hours and without any readily identifiable cause, such as structural neurologic disease. Hashimoto's encephalopathy is a condition of presumed autoimmune origin, suspected in the presence of high titers of antithyroid peroxidase antibodies that can often present with seizures and has been described as a cause of NORSE. It's usually highly responsive to treatment with corticosteroids. This is the first reported case of NORSE and Hashimoto's encephalopathy associated with mRNA COVID-19 vaccination. A 20-year-old female with a past medical history of hypothyroidism presented with new onset seizures. Her family members described recently worsening behavioral symptoms, including depression, anxiety, and anger outbursts, as well as insomnia, but without clear psychotic features. A thorough review of systems was otherwise unremarkable. Her seizure semiology was of behavioral arrest, aphasia, forced gaze deviation, and non-forced body deviation. Her EEG showed bilateral independent temporal epileptogenic discharges, and her seizures had a focal onset over the temporal head region with secondary generalization. Here on the poster in the middle, we can see strips A, B, and C of the EEG. A with seizure onset over the right temporal head region, characterized by spike and wave discharges with phase reversal over T4. And in B and C, we see the secondary generalization of the seizure and spread to right frontal central head regions and then to the left hemisphere. She rapidly progressed to status epilepticus refractory to three AEDs with clinical and electrographic seizures. She was afebrile, and a physical exam was largely unremarkable. Workup was negative for infectious, paraneoplastic, and autoimmune encephalitis etiologies, except for elevated antithyroglobulin and antithyroid peroxidase antibodies at 307 and 377 respectively. She was treated with pulse dose intravenous methylprednisolone and IV immunoglobulin with no response and required medical-induced coma with burst suppression pattern with midazolam drip and the addition of phenobarbital. Her anti-epileptic regimen consisted of lacosamide, lamotrigine, perampanel, topiramate, and valproic acid in addition to prednisone. She then underwent 5 rounds of plasmapheresis and was finally able to wean from pentobarbital with addition of phenobarbital to her AED regimen. At short-term follow-up, she's recovering with some memory loss and has had failure to wean from AEDs due to breakthrough seizures. The recognized mRNA vaccine side effect profile is relatively benign, usually with local reactions, fatigue, and headache. A more severe adverse effect, myocarditis, has recently been recognized with higher incidence than expected. Cases of primarily neurologic adverse events have been rarely reported, including Guillain-Barré syndrome, encephalopathy with non-convulsive status epilepticus, and encephalitis with myoclonus and Sweet syndrome. Our patient's prodromal psychiatric symptoms appearance coincided with the administration of the second dose of the Moderna vaccine, and although the association cannot be definitively made, the presentation was consistent with the onset of Hashimoto's encephalopathy after a dysfunctional immune response to receiving the mRNA vaccine. Thank you, and below are our references.